Good afternoon. Welcome into the Senate Committee on Government Operations Committee meeting of Friday, May 22nd, 2026. As I mentioned before we went live, for the first time this year, I can see a light at the end of the tunnel. I am in great hopes that we will be saying goodbye to each other in a week. Most of us to return, hopefully. And anyway, I think there's finally some serious movement on the education bill. And if I know this building the way I think I do, the other dominoes will fall quickly in terms of the budget, the tax bills, etc. So we're going to wrap the week up today with testimony from Drew Hazelton, who's chair of the Vermont EMS Advisory Committee. Join us, if you will, Drew, at the table. And I know you have somebody with you. And if they want to move up too, they can. If you just want to sit from where you are, that's fine. Good. Do you know everybody?
Yes, we've met before.
Great. Senator White is in Texas for an event, and she will be returning on Tuesday. And Senator Clarkson will join us as soon as her conference committee is concluded. So we're yours for the next half hour or so, and welcome in. Hopefully you had a good trip up.
Yeah, I did. And thank you for giving us the opportunity to come in. Drew Hazelton, I chair the EMS Advisory Committee. And Pat, you want to introduce yourself?
My name is Patrick Malone. I'm from the University of Vermont, and I'm the vice chair of the committee.
Welcome.
So I have a quick presentation, if that's okay.
Sure.
And
yep.
Does that show up? All right. So, and I'll go through this really quick because this is the information that we submitted to the committee back in December as part of the assessment you asked us to do. So we were asked to look at the entire EMS system, specifically looking at funding, costs, how things are paid for, workforce development, education, and so on. So we did that work. We hired ourselves a consultant, and they did a bunch of work for us. And then we also did a lot of verification and stuff for ourselves. So we looked at everything. From the structure to the EMS office to the rules to the statutes, what we're currently doing that matches the rules and statutes, and what's happening in Vermont EMS that doesn't. We struggled a little bit with data around everything. So we put this data disclaimer in the report we sent to you, and we're continuing to struggle getting good, accurate data through some of the Vermont data collection systems. And, you know, again, the whole word I use it for training for some folks, but here's the kind of meat and the potatoes of what we got going on. We have 100,000 plus EMS calls in Vermont, annual 6% growth, another 30,000 calls for moving patients from one facility to another. And then about 30,000 where we're actually going out to people's homes, taking care of them and not transporting. So,
does your advisory committee advise both private EMS entities and public or hospital run? Does my question make sense?
So the advisory committee was created by legislation to advise the commissioner and the legislature, and it has representatives from all of the EMS districts, all of the professional organizations, ambulance association, professional firefighters, fire chiefs, League of Cities and Towns, the hospitals. So it's a pretty big group. There's actually 21 representatives. We elected to have alternates, so we really have 42 members that are working as part of this project, simply because of the amount of work that we had going on. So again, just kind of basic statistics around what we have going on for first response, along with our ambulance services. So we have about 75 ambulance services total serving the state of Vermont. That's not ambulances, that's individual organizations serving the state of Vermont. So we also have a handful of out-of-state services that are coming in and providing water level service. Some of the areas we're working in that are a little bit unique. We have some ski areas that have unique arrangements for EMS. We have colleges that have unique arrangements. So there's a lot of kind of different ways it's being done in Vermont, and that creates a little bit of more complication when we talk about the plan that we're putting together for you.
is being done about the people operating in the state without a license? That seems really problematic,
So, so right now, nothing.
right?
We are as part of the plan, and like I'll pass out some documents. It's kind of what we got to this at this point. We will be recommending as part of our plan that in the future we require people that are operating in Vermont to be licensed. The larger EMS community thinks that's a good idea, so we're in support of that.
Mhm.
You asked us to look at costs and see, what's happening in Vermont. We figured out through a whole bunch of, again, different data sources that we're spending about $98 million a year to provide EMS services in Vermont. Roughly half of that is coming from direct reimbursement from insurance companies. The rest of that is coming from a large percentage is coming from local property tax appropriations to support EMS. So as a healthcare service, we're spending about we're receiving about half of our funds statewide from municipal taxes. We didn't only look at our system from the finance and from the area of workforce development, but we looked at medical system performance, and not everything we found was great. Right? We looked at individual measures for different districts around the state, looking at clinical and operational findings. And we found out that there are some areas where we are doing better than the national average, some areas we're doing worse than the national average, and some areas where the data that we are able to collect in launch.
Actually,
So we're utilizing this information and we're making recommendations as part of our 5-year plan on how to continue to monitor this data and improve the actual operational clinical outcomes. So, and there's a lot more information behind all this should you guys be interested in some more of the details. But you'll see that, we are not necessarily performing at the level that we wanted to across the state. Some of this is data collection issues. Some of it probably is that we're not performing at the level that we would like to. So we're looking at system improvements. This has helped drive our conversation around education, workforce development, and continuing education in order to help provide better clinical and operational outcomes. We looked at access to education. I've spent 10 years talking about workforce development and trying to get people into our system and support it. And we've received a lot of support over the years. So this is what we have for people. I would love to say that we've been making huge strides in the number of EMS providers in our workforce, but really we've been pretty much just barely keeping our head above water. From a numbers perspective, we haven't really gained a lot in the total number of people. So it's been about 3,000 EMS providers for as long as I've been coming in and testifying this committee. So despite
despite all our efforts, we're still
we're
only at
still
that.
holding there, yeah. Now the question is, without our efforts, where would we be, right? So I wouldn't say that the efforts have not yielded good results. I just think that post-COVID, we probably would have been way worse off than we are. But one of the challenges that we're looking at is we're seeing an annual, it's a 6% year-over-year increase in demand for services and essentially a flat workforce for really as long as I've been coming to this committee for almost a decade. We looked at who is teaching, and this becomes really important in our recommendations for how to improve our education system. Where are those happening? And about 7-8 years ago, we changed the education structure, created a new level in our senior instructors, and we can see it for the most part, they're the ones that are doing the bulk of our education. We looked at access, making sure that every corner of Vermont had access to EMS education currently. And what we determined over a 2-year cycle is that we were doing a pretty good job. This is where a lot of that investment did play out for us. Is we do have a good geographic distribution. Though not perfect, we have a pretty good geographic distribution of education going on in Vermont. Here's a map. There's a couple of areas that are a little bit more challenging, where it's a bit more of a drive to get to EMS education. So we're utilizing this information as part of our 5-year plan. And many of the areas that we're struggling have already been corrected since this data came out, and we've been able to shift resources and fill those in. this year. And this information is 2024 information. So we were gathering the information last year. We've been as a system taking steps to try to improve that. And this is our advanced EMT data. At the advanced EMT level, it's a bit more difficult. Again, something that we're looking at and hopefully going to be able to make some progress on. And you can see the number of classes based on the different districts. District 3 being the Chittenden County area would make sense. It would have more area. District 13 is where our academy is down in Newfane. See why that's got a higher spike since more programs have come out of there. So we know that EMS is not just 911 calls, but EMS does to make patients from where they are to definitive care, from definitive care back to nursing homes or hospice care. So what are we doing in that? About 28,000 runs a year are being moved between facilities. We looked at how that's being done. For the most part, there are 6 out of those 76 services that are doing the bulk of the interfacility transport work. And we started looking at what type of services do they need? How acute are these patients? Are they critical? Are these life-threatening transports, or need more transports for hospice or routine care? And what we found over here in the kind of the right-hand column, those are your super critical patients, and we really have a relatively small number of those. The majority of the needs that we have are in that subacute category. We looked at when they happen, what time of day, what day of the week, trying to figure out is there a way that we can put forward a more efficient and a more effective transportation network. So we're utilizing this data as part of the information that we're using in our plan that we're preparing. So we had to come up with methods to collect our data, and again, stop me. I'm trying to get through this quick because I know we're holding you guys from the weekend. So we were asked to look at what is the volunteer contribution, what is the cost. So we had to make some assumptions, and these are our assumption slides. So everyone knows what we used. And then our group looked at the EMS system in Vermont in a few different ways. We decided to slice it by size. We wanted to know, is it financially different for a small service versus a large service? And we also wanted to divide it up by governmental structure or organizational structure, governmental, non-governmental. So we took all of the data and we parsed it both directions. We looked at it to see what we could learn. And this is what we've learned. So these are small, the smallest services, and their call volume and their cost, the average per capita, that is the cost that the per taxpayer in their coverage areas is paying. So their average cost per call, about $800, average cost per citizen to have that service available is about $75. The mid-level services, cost per call goes down a little bit, cost per citizen goes down a little bit. That would, generally probably make sense to most. And then what's kind of interesting, and I find it interesting, is actually once you get up, you start seeing the cost go the other direction. And that kind of plays out a little bit in the other slides. So we looked at municipal, the data around municipal services. Some of and again, we had to make assumptions in our data sets. So there are currently 10 services. They're providing 18 towns worth of coverage. Only about 2% of the actual geographic area in the state, but 19% of the call volume. About 27,000 calls. What was interesting is most of these are all fire-based, and some of these departments are doing as much as 92% of their work on a weekly basis or yearly basis is actually EMS work, with the lowest amount being almost 60%. So even our career fire service-based ambulances our services are doing mostly ambulance work at a rate between 60% and 92%. They do very little in the world of intercity transport. So that second half of EMS, they only supply about 3% of the hospital work.
I mean, what does the broken leg fall? I guess that's not exactly emergency.
That would go in the emergency category because it's generated through the system. The non-emergency category would be like going from your local hospital back to a nursing home or going from your local hospital to another hospital. So they only participate in about 2% of that activity.
Now, would it still be considered that sort of inter-facility transfer if someone was, say, going from Northwest to UVM Medical Center because they couldn't provide the necessary care?
Yes. And when we, as part of our plan, one of the things that we've put forward and that we will be making recommendations around is clearer definitions.
Mhm.
So part of the challenge around our data collection is the word interfacility transfer, the phrase interfacility transfer actually means different things to different people across the state. So getting accurate data was very difficult for us. So we put together some language already that we'll be recommending so that that documentation is more consistent and everyone understands what box to put things in.
That makes a lot of sense because I think it's probably a different set of resources and needs if you're transferring someone from a hospital to a nursing home versus transferring someone whose level of trauma exceeds the ability of that receiving hospital.
And that we've had a lot of conversation. We have a healthcare integration work group that's working on trying to figure out how those mechanics work as part of it. So as far as the costs go, about $34 million of our EMS spending goes to this class of provider. Their average cost per call is $1,168. Average reimbursement is about $476. So you can see the gap, and I think most people have probably seen it in your municipal budget as the numbers creeping up. We separated out strictly municipal third-party ambulances or third service providers because we want to look at those. It's about 11% of the state. They have about 10,000 transports. Their response times are about the same. Only 2 of them provide inter-facility transport, and between those 2, Berrytown being one of the largest ones, they provide about 11% of the inter-facility transport business. Their costs per capita around $57. Range from 6 to 163, average about 57. They're also seeing average reimbursements around $476. So their cost per call is $800. So that's the gap that we're currently seeing in municipal budgets. You've got 19 regional ambulance services. We define that as services that are covering more than 4 separate municipalities, the way that we defined it. They cover about 52% of the square mileage in the state. And I'll provide this slide to you if you guys would like it.
Yeah, it would be kind of to send it to Lynn so we can post it. It will be helpful for next year conversation.
About 43,000 calls. They do provide the bulk, so 37%, largest number of 47% of the inter-facility transports that happen. Their average cost per capita is about $31. Average cost per call is $670, and their average reimbursement is about $665. So as far as the numbers go, this is the least tax burden of the 4 that we looked at. And then when we put in a category less than 4 towns with local ambulances, just the way that we categorize them, there's 18 of those services around, about 1,100 square miles, 15,000 calls, 12% of our inter-facility transport work. Their average cost is $53 per citizen, and their average Hospital Call is about 729. We did have a interactive map added, so if you're interested, there's a link I can send, or you can click on any town in Vermont, and it'll tell you what the cost per capita and cost per call is. So we put that together for you, so you can look at your own or compare if you so choose. And then we looked at some of the other college-based services and ski area services, but they don't really fit in these categories, so they were kind of separate. So that's a very quick overview of a ton of work compiling data. We have multiple other reports that go with this, but I wanted to kind of put that up there. Our report is in your already in your collection that we submitted in the fall. But we've been utilizing that since then, is what I really wanted to talk about. So we took the legislation where you asked us to do an assessment and you create a 5-year plan. We split it into 2 separate distinct projects for us. As an advisory committee, we did the assessment, and that's what I just kind of really blew through real quick. And now we're utilizing that assessment to build a 5-year plan for a statewide EMS system, which is what you asked us to do. So in order to tackle that, it is a massive project. Our group is made up of representatives from every district. Each of the stakeholder groups, all the professional organizations, the leads, the hospitals. And we had a conversation about whether we wanted to hire this work out, like many groups do, and have some consultant write a report for us. And this group was adamant that they wanted to do this work themselves. That the experts that we were seeking were the ones that were in Vermont doing the work, and we wanted to be able to bring in subject matter expertise. We wanted to do the work. That was a huge decision and a huge amount of work. So what we decided to do is we decided to give every one of the named committee members an additional alternate to go from a 21-member group to a 42-member group, so that we could then divide those into work groups and start tackling these as smaller groups. So we have multiple work groups that are working on this, and we are actively going through data that we collected and coming up with different, I'll pass these around. I don't know if you guys get this electronically too. So, and I do have printed copies of slides if anybody does want. Yeah, I've been photos. That's amazing. And I actually have to report if anybody wants to take home a paper copy of our reading report. So we've been going through and looking at the EMS system as a whole, looking at the data, and these work groups have been meeting every week. So I can't emphasize enough the amount of energy and work. So we have Pat and I have the pleasure of sitting through a lot of meetings. We have 3 meetings a week in person in Vermont, going through and writing up the consent items that are then being moved through our system, through our advisory committee, will eventually become a report. I think some of the message that I wanted to give you guys today is that we are actually going to be on time, and we are going to be on budget. So I don't know, you guys probably don't hear that a lot in this building, but we, at the rate we're going and the work that's being done, I am confident as the chair of the committee that we will be providing you a 5-year EMS plan and recommendation on time this year. What's sitting in front of you are the first 21 consent items that will be rolled into a plan. And this is really important to me because we've gotten to this point where I'm not going to tell you that every one of these consent items move forward 100% unanimously, but I can tell you that out of the 21 consent items here, there was a total of 2 nay votes, total of 2 nay votes across the entire group. So we have worked really hard with these 42 people from across the entire state, from, again, every professional organization, to really think about what the system means and what the system needs in Vermont, which I think means our plan is going to be pretty robust.
Senator Moreland.
So we have all these emergency unit up where we are. We actually do a lot of transfers for UPM. And we go down to Tennessee, Pennsylvania, and Quebec City. One of the issues I'm discovering is you've got Newport up there where we are, and and they've gotten bigger, we've gotten bigger. And you got Glover, who's fairly small, you know, just like, you know. And there's some pilot programs that are starting to go around here, with sheriffs. And I'm just wondering if, in your consideration, whether or not you look to regionalize or county, go look at it countywide, these types of services. And we were thinking of going to like a county tax or something like that. I didn't know if that's something you guys have pondered and thought of. But one thing that's happening is all the police departments are poaching staff and one another. And so you're competing constantly with other departments as far as pay, as far as healthcare, as far as retirement. And it's a vicious, it's just starting to be a vicious cycle.
It's a feeding frenzy.
And I'm not exactly sure how to get around that. And we're really small, as you said. There seems to be a sweet spot right there. But I have a lot of concerns. Our communities, they almost gave up on it. And then our trustee said, no, let's look into this. And now it's a nonprofit, but now the Village of Orleans is doing all the financials, all the payroll, all of that. And we have some very dedicated people there. We seem to be pretty strong, but I just didn't know if that was something that you had thought of when it comes to looking at moving these types of services outward.
They have been thinking of it because we've been thinking of it with them.
So we won't see it here because we have not gotten all the way through the consensus of the entire committee. Our governance work group is actively talking about what that looks like. So we have a governance work group, we have a finance work group, so looking at the, you know, both kinds of halves what we're talking about, the finances and what it would look like. So I don't believe you're going to see any recommendations that come out of our committee that's, you know, talking about forced mergers or anything like that. But I do believe, based on the conversations that we're having, that people are ready to have conversations about whether it's regionalization conversations or consortium conversations, if we can get them the support to do that.
Yeah, and I don't want to force either. I that's not fire services are the same way.
Yep.
You know, we're having the same issues with fire services, still training.
Absolutely.
Unlike our friends in education, we have been adamantly avoiding the term regionalization. It's, even though you saw the numbers, we try not to use.
You're so much better for
Yeah.
everybody.
We don't like to use the R word, and to kind of help set that environment, the state EMS system is divided into districts that historically based on the receiving hospital. So that's why it's 13 instead of 14.
Okay.
Yeah.
That makes
And
sense.
one of the things that I think almost every committee member is supportive of is to go from 13 EMS districts to EMS District 802, one district, and to kind of to break down the barriers, some of which it's easier for 5 towns in one former EMS district to collaborate.
Yeah.
Then all of a sudden you go across that district line, which are just artificial lines anyway.
So another thing that's really bothersome to me that I haven't dove into yet, being down here, but I'm going to, is the fire tax, or ambulance services. I can't remember what the rate is, the 1.5% to
3%.
3%.
3.3.
And it's becoming a lot of money that these services are sending to the state of Vermont. And then I think legal is on the general fund is what's happening. But you're already not paying these entities much. You're already not paying enough for Medicaid, Medicare, just like you are in other health associated services. But if you bring a patient out of state, if those revenues are not subject to the provider tax, and so I'll probably be doing something with that next year if I get reelected. So driving me nuts.
This may be your baby next year.
The challenge is, you know, EMS faces lots of challenges. Workforce development is one of them. Payment structure is another one. So for us, most all ambulance services, the majority of our revenue comes from federal payers, whether it's the, state-run federal payer or the federal-run federal payer. And most of our patients, large percentage is Medicaid or Medicare. Unfortunately, we don't get to pick our Medicare rates.
Especially in the rural areas.
Exactly. And then and we have not seen growth in Medicaid. So our Medicaid rate has been unchanged for quite a few years. The provider tax came about because when we had that conversation, the Medicaid rate in Vermont had not changed in well over a decade. And it was the only tool we could use to help improve Medicaid rates. So what's happened is since the provider tax came in and it increased the rates, so for the most part, the vast majority, I think there's only a couple places that were that had high Blue Cross areas, were getting more back from their provider tax than they're putting in. The challenge is Medicaid has now stayed stagnant for so long that the percentage that you're paying because of the very small increases in Medicare and those private insurance is now changing that off. So, but if we were to do away with the provider tax and not do away with the Medicaid increase that was associated with it, I don't think you'd find anybody that would be upset about that.
Yeah.
But what we would not want to do is go back to the Medicaid reimbursement rates that we had pre-provider tax. Because the Medicaid, you can see on the slide, we're receiving in every category less per call than it's costing us to deliver them.
Yeah, it's ridiculous.
The other thing that, and I've been saying in this committee for, like I said, a long time, every time we ask a local municipality to pay for Medicaid services with property tax dollars, we're missing out on our federal match.
Yep.
So, and we haven't changed that in the whole time we worked on it.
And the only reason you need municipal match is because it's not covering costs.
Right.
So we're having to go to all of our communities and ask for more money, which they understand, by the way, because they want the service.
They're only willing to pay that match or the gap, because everyone wants.
Correct.
And so it's so much more efficient regionally. And you are in the region of the Wyndham Sheriff's regionalization work
And
and his pilot. And I am wondering how you might emulate that elsewhere, even maybe in the same region.
so what's interesting is a lot of his program is actually based on the way that we do business. So actually the Sheriff's Department and Rescue Inc., can take my advisory hat off, we actually have a consortium already. So we work together to provide paramedic education. So we're already connected. We do a lot of work together, our organization and the sheriff. And part of the kind of the thought process behind his is the way that our regional model works. So we serve 14 towns. They all pitch in and we're able to move our resources and assets within those 14 communities. So for example, not last Tuesday, the Tuesday before, the town of Newfane, which is 1,200 people, happened to have 5 emergency calls that all came in within 30 minutes. All 5 of those emergency calls got ambulances. They all got ambulances within a very short period of time because we were moving assets. As soon as the first call came in, we were backfilling it with one from other regions. So none of them went unanswered. In fact, we have not missed an emergency call in over 10 years. We have 100% batting average for the last decade. And it's because it allows us to shift and move resources. And that's what the sheriff's proposal is really about. So I completely support it. I think it's a great idea.
We'll be watching it, see how that develops. Senator Yoski.
Do you have a sense on average in any given year how much federal money we've left on the table because of the way we're funding and doing things?
I don't have that number, but it's something our finance group is trying to put their hands on.
Well, thank you both.
Yeah.
Patrick, good to see you. As always, Drew. I
Yeah.
think I've been here for all the 10 years you've been coming in here.
Me too.
Yeah.
Thank
So
you.
have a great weekend. A somber one.
Yep.
And thanks for your
Yeah,
service.
let's hope you have very few calls.
Yeah, like none.
And I look forward to next year laying this out through and maybe getting some legislation around our new EMS system, because I think we're gonna have a pretty good product put in front of you next year.
Great.
Which is terrific.
Thank you.
And
Appreciate it.
yeah, it was terrific. Thank you.
Just remind me, are you one of the people at the table for the county governance study group? Because this is sort of one of the many layers of our program.
Yes, I think you were.
We were not.
Oh, you should.
We,
Yeah.
Well, I'd be interested in participating if it was, come up.
Yeah, no, we looked at the sort of quilt of different services provided in different ways, and your layer of service was certainly in there. But I think it's an important part of that conversation.
Okay, I'd like to talk about 907 before we adjourn. So thanks again, guys.
Thank
Great
you all
to see you
for
as
your
always.
time.
Thank you,
Yeah, sure,
Gwen.
thank you.
We'll see you again.
Gwen,
I hope so.
thank you.
Thank you.
This was on notice today on the calendar, 907, the
Yes.
reporting requirement bill. Chair Marcotte of the House Commerce Committee has fashioned an amendment, which you all now have a copy of. So I would urge you all to take some time this weekend. We're not going to go over the whole thing. It's a 9-page amendment. But I'll let Tanya speak to the driving force behind this, and then I'd like us to be able to concur with the House proposal of amendment, so when it comes up on the floor on Tuesday,
I'm
she can get up and say that.
I'm chair of the committee. The amendment came out of mostly because it's our sister state amendment. It's our sister state bill that Brandy reported on the floor.
Okay,
And this is.
well, that's
this is
the
a great job.
I didn't mean to, she's the reporter of the bill.
I know, so I'm just saying, I'm happy to talk to, but we could even vote on this today if you wanted.
That's what I,
Yeah.
that's what I want.
I've read it. I've gone through it.
Good, well, it's,
Yeah.
So in 25 words or less, what does it do?
I mean, I think Senator Clarkson nailed it. It takes the bill that the governor vetoed, removed the part he found objectionable, and puts it into the
Okay.
reports bill. They didn't actually change any of the work we did on the reports.
Right. They just, this is that, this.
Yeah, it was a via.
this was the vehicle that we used.
Right, exactly.
Okay,
And this is the sister state bill that Randy
Yes.
reported, that you'll recall, that creates a system for how we evaluate which countries and
Yep.
cities and maybe cities that we decide to create a sister state program with. The governor objected that to the board, or whatever they call it, the advisory council being able to terminate things, that he thought that was not constitutional, and so they changed it, fixed it, and that is in that fix is incorporated into the sister state bill and is set back.
okay. So, show of hands, straw poll, we vote to concur. Okay. And you will have our guidance and support for your report.
Should take only one thing.
And if you want
Only
anything,
as long as I make it take.
and if you want Randy to report the sister state of it, you're welcome to defer to him on the floor. And you just tell me at the fence.
I'll just mention while we're still online also, there are 3 other House proposals of amendment we'll take up. I don't know, to be honest with you, whether we're gonna have the opportunity for the Williston Charter. We need a Rules Committee meeting first to release it, and then we'd have to take testimony. I don't know what it does. I don't know if it's one of those things that has to happen this year, or if it's just a sort of a housekeeping charter change. I don't know where that goes. Based on what the pro tem indicated before we adjourn today, with double sessions all next week, I'm gonna get a hold of both Tim Ash and Justin Kenny over the weekend, just to tell them we're not gonna be able to have them come in Tuesday. My guess is we'll start at 10 in the morning, right?
Yeah, that's what he said.
We'll go it till probably noon, 12:30, break for lunch, come back in the afternoon. Could be another 2 hours, could be 3, could be 4. I don't know. So there's no sense in having people sitting here waiting in case we can't make it out too.
You-
So,
Yeah.
Have we done this before? Is this the way this?
yeah,
Okay. So the house.
we may have more than 2.
Alright.
This gets to the point where you gavel in,
Yeah.
get a quick report from the pro tem, gavel out because we
Okay.
have about.
And then you go see the slideshow. That is your moment to go and see the slideshow.
Okay.
The legislative slideshow.
So is there anything else to come before the committee today?
No, I'm thrilled we acted on 907. That's great.
Yeah, well, I just try to keep ahead of just one step ahead.
You are so ahead. I am so impressed.
I wasn't fishing for a compliment. I really wasn't.
That's okay. I am happy to give you one.
Okay, so